My name is Joel Fein. I am a pediatrician and emergency medicine physician. I work at the Children's Hospital of Philadelphia, and I've been involved in kind of social issues around medicine for my entire career. So my first introduction to the concept of trauma was as the board chair of the Institute for Safe Families. I had been doing pediatrics and pediatric emergency medicine for a decade or so before I became involved in ISF. And Martha and Sandy and you introduced me to the concept that really explained a lot of what I was seeing in my work on a daily basis. And it contextualized it. It also helped me treat my patients differently, even though it was on an individual level on a case-by-case basis. The Institute for Safe Families was a small nonprofit organization in Philadelphia that started out working mostly in the intimate partner violence arena. And then as the thought processes evolved, realized that IPV was really one of many adverse child experiences that occurred that impacted the entire lifespan of a child and eventual adult. As such, ISF, Institute for Safe Families, started to work more in the ACEs arena and got a number of summits together and I guess collaborated with a lot of the people in the city who were truly pioneers in bringing ACEs to real-world activities. I became aware of the Adverse Child Experiences study as a young attending in the emergency department, and as a researcher, I truly appreciated the way that it scientifically explained what I was seeing every day in my work in the ER, with kids especially. I don't believe there's one person that made me see the light, but there are a number of examples I can think of where having that ACEs and trauma mentality helped me as a supervisor in the emergency department guide the correct therapy for my patients and their families. I can remember one kid in particular, he's a 4-year-old boy, came in on a board and collared after having a minor fall, but was completely mute and completely shut down. And the resident came out and said, "We need a CAT scan because this kid's unresponsive." And I said, "Really? Because it doesn't make sense from what they told me happened." So instead of rushing him to get his brain irradiated, we brought a child life worker in to work with him for a few minutes to make him more at ease, because what had happened is his life was pretty hard up till now, and his reaction to the pandemonium of being treated by emergency medical systems was that he would just freeze. Within 5 minutes of working with him, he was up, playing with toys, and I was able to not only for myself confirm that this is something that we really need to learn, but realize that there's a lot of teaching that we have with our trainees and upcoming medical personnel to really bring home some of these concepts. So some of the changes that we are bringing to CHOP, I have the honor of leading something called the Violence Prevention Initiative. And that's kind of a whole hospital violence prevention effort that works at multiple levels to prevent violence in the community and in our schools and really in our medical system. Our entire training core is based around trauma-informed care and teaching our hospital staff, personnel, everybody who comes in contact with a kid or a family about the concepts of trauma. And that can range from just basic Trauma 101 to truly training people in CFTSI and other psychological, interventions that can deeply affect a family. We have currently trained at least 1,200 of our staff at this point. There's 11,000 people that work in the CHOP system, so we have our ways to go, but we have truly established the trauma-informed training of healthcare personnel model that we would like to adopt in our hospital. One of the challenges is that every time we teach this, we get another person who's at that training who wants us to train another group. So we're doing this actually by request right now, and we've also now established what's called a learning link, which is something that you can go online and literally in 15 minutes get the basics of trauma that will be available and possibly even mandatory for our staff as part of their every year re-upping of their modules that they have to take for being a staff member at CHOP. So the ACEs task force is, for Philadelphia, started from the Institute for Safe Families, which is the organization that really brought adverse child experiences to the medical and now expanding past medical community. We have a large number of stakeholders from many disciplines in the city, and it started out as predominantly pediatrics and medical, and now expanded to social services, criminal justice, education, and others. It's an organically derived group. The more people that hear about it, the more want to join. The task force really started as a learning collaborative for the first year and a half, and then we decided, okay, we need to take these concepts and really figure out what do we do with them, as opposed to just learning and appreciating them. As such, the task force developed 4 different arenas in which we can work: community education, professional education, practical interventions, and research. And we have these small work groups within the task force that communicate with each other, but mostly work in their area to get something done using the information that ACEs and trauma-informed care provide us. In bringing these concepts to people that we connect with, both in the healthcare community and outside that community, there's initially an incredible resonance that ACEs have with people. This is the aha moment that we see when we describe the science and the brain science behind what people are experiencing, similar to whatever I experience in the emergency department with my patients and families. Then, when it comes to, well, there's a certain helplessness that you have when you now engaged someone in this conceptual framework, and then now it's like, what do I do with the information? How do I take this? How do I use it? And I think it's really important to provide example after example of how they're already using it, and we're naming it, but then how to take that and even go a little bit further, and I believe it would be institutionalize the work that they're already doing and some of the advances into policy and institutional work.
Good.
One of the areas that's come up in every community meeting and even in our hospital meetings is the strained relationship that can sometimes happen between police and community members. And this is, of course, in the news lately, and it's something that people are very well aware of. What we find is that similar to every social service group and every education group, in general, police want to have that good relationship with the community. So we've started to learn a little bit from police themselves about what they would think about trauma concepts and ACEs concepts, and understanding that they do want to learn a little bit more about what they're seeing in front of them when they're interacting with someone, the genesis of that, how that happens, that interaction. And it also is important to realize that the police have their own trauma that they bring to this. A lot of them have been through wars either abroad or actually on the streets where they work. That simple recognition that this concept exists is important for them. The issue that with police compared to social services or education providers or physicians and other healthcare providers is that the police's role is not just to help the individual in front of them, but it's to protect all of the individuals around that other individual. So they have a bit of a different role than all the other providers that we're contacting. And so I think a unique approach needs to be taken, because they must see themselves as different from the other systems in which we're working. One of the main programs that we have in the Violence Prevention Initiative is the Violence Intervention Program. And that program works with assault-injured youth similar to many other good programs in the city, our clients or patients happen to be younger. For the most part, they're 8 to 18 years of age. We have truly incorporated a trauma-informed approach to violence prevention in those children and families. VIP provides wraparound, very intensive care for the youth that are enrolled in our programs, and we also apply it to their siblings and their parents and all the other family members that are involved in shaping their life. As such, we realize that it's not just the event and the youth that we're working with, but it's all of the trauma that has occurred to that family and to that youth throughout their entire life that will form the trajectory for that youth and family. One of the pleasures that I have is that we have master's level social workers who truly embody the trauma-informed world, bringing their approach to that family and that youth. They provide everything from support in the educational world, getting kids transferred or help with school, to helping them through court dates. And not only are they trauma-informed, but they force other systems in which that are connecting with these kids to be more trauma-informed. So they work with DAs, they work with teachers and principals, and they educate them as much as possible in how to not re-trigger this child and family so that they can succeed in those systems. The National Network of Hospital-Based Violence Intervention Programs is a conglomeration of the trauma-informed violence intervention programs that work with assault-injured youth and even up to adult range. There are approximately 30 programs in the country that have joined because we all found that we were pretty much doing the same thing in different cities and different communities, and we use the NNHVIP, National Network of Hospital-Based Violence Intervention Programs, to share with each other on many fronts how hard this work is and how to make the work easier because we all learn from each other. So we have a research work group where we're trying to figure out how to support what we're doing by proving what we're doing is working and that it's cost effective. We have a workforce group that effectively the call is like a therapy session for those who are on the front lines who really, as we know from secondary trauma and the work that's being so hard, really need the support and understanding that, oh my God, everybody else is going through the same thing I am. And they talk on the phone once a month as well. We have a national conference that everybody gathers for every year to discuss the issues and bring cutting-edge work to our lives. There's a mental health work group and a policy work group. So we're thinking about how can we take what we learn and through policy not only support what we do, but spread out the word and get other programs to work in the way that we work. One of the goals for the leaders of NNHVIP, and that includes myself, Dr. Corbin, and Ann Marks, is to really bring trauma to the forefront, trauma-informed care to the forefront of what we do. And if we see a program is straying from that method, we try to work with them to say, okay, maybe the Scared Straight program is not what you should be doing. You know, maybe we should think more about not re-traumatizing our children or our adults and bring that program back into what we think maybe on a long-term level work better. One of the other avenues that we pursue, and this is a little bit unique for pediatrics, is screening for intimate partner violence. And through the Institute for Safe Families and their relationship with Lutheran Settlement House, there is the Children's and Moms program, which is working in 4 different hospitals in Philadelphia. And we're a collaborative group to help clinicians in the medical world screen for intimate partner violence. This is a little bit unique in pediatrics because that person you're screening is not your patient. And you have to be a little bit careful of where, number one, you're stepping on the toes of adult providers who are already screening, but more importantly, is it really your role? We make the case that, yes, this is your role because the most important thing in that child's life is probably not the reason you're seeing them. in the medical community right then and there. But it could be this home environment that's truly shaping their health, both short-term and long-term. Making the case is pretty easy. How to do it is a little bit more complicated. And so at CHOP, we've tried to incorporate a very, a pediatrics-aware process by which we don't document in the pediatric chart anything about intimate partner violence, but still enabled us to screen under something called a home environment screen that says yes, and then use an outside database to then put all the information in that Lutheran Settlement House and other organizations could feasibly get by accessing the database for that particular person that we screened. So we're protecting the safety of the parent while still enabling screening in the medical setting. One of the things we're finding is as we talk about intimate partner violence screening, and I just gave a lecture the other day to a group of nurses who I wouldn't ordinarily think would be doing this. They're in the operating room, in the radiology, and it's not exactly the place where you'd think, primary care and even emergency department. They were so interested in being able to be trained and do this work because they sometimes are the only people that actually get to meet the single provider that is with that person in the operating suite or in the radiology, where the provider is actually, or the single parent, where the parent's actually separated and there's one parent with one kid. So they say, we may be primed for actually doing this kind of work. How do we approach this? It's not that easy. Timing is an issue, and they have a lot of throughput issues. And so we're planning to establish a work group in our hospital just for that group of people who are not necessarily the classic providers for domestic violence or intimate partner violence screening, but have an interest and a passion to do it. So we work with our frontline providers to establish the processes without just saying, okay, just do what we do or do this, because every area of the hospital and every area of the healthcare system is a bit different. And you need to work with the community, meaning the providers, to make that work for them, as opposed to just pushing down something that you've already thought was good. I think we have been seeing a substantial change in trauma-informed care, even though people may not be recognizing it with the buzzword trauma-informed care. When we present these issues and the information and the science behind trauma, it absolutely resonates with almost everybody we're talking about. It sometimes actually triggers them, which is important to know when you're talking about it and teaching it. The challenge is really to move that passion and that truly emotion into action, so that the important thing for us to do now at this stage is to create actionable, small, but feasible activities that can really embody the concepts and the science that we understand. And we're at that stage. That's the cutting edge of the work right now, is to make things work on the patient, provider, client, individual level, once we now have folks who are resonated and understand what trauma-informed care and ACEs are all about. I think it's actually dangerous to provide people with the need to do something without giving them examples of how to do it. I think it can lead to learned helplessness, and it can lead to frustration. So one of my goals when I teach and talk is to give example after example after example of how this information is applied to directly what people are doing on the ground. If we don't do that, then I think we're actually going to head backwards. I'm going to say, I know I should be doing something, but I feel helpless, and therefore I'm going to remove myself from even trying. So I think it's really important. We have an opportunity and an obligation to make that happen. I think similar to any institution that starts to work in trauma, as a city, if we're working in trauma, we need to break down the walls and learn what everybody's doing, what has worked, and importantly, we have to share our failures as well as our successes. Because if we don't, people are doomed to repeat what we've already tried. And I can tell you there are many times when what we've tried has not worked. So there's got to be a safe area and a safe haven for people to discuss these things. Philadelphia ACEs Task Force is one of them. I think we do provide a safety net for people who to say, look, I'm not here to promote what I'm doing. I'm not looking for funding from you. I'm just here as a group to share. That's not policy, but that's a sanctuary, so to speak, for people who are doing the work, because the work is hard. On a city level, I think that we do also have to move from concept to action. And I think that truly funding needs to follow the policy. So at this point, there needs to be a reward for people. There needs to be some way of, in supporting the work that is done that is not direct patient care billing code, but is still the important work of trauma-informed care. One of the kind of dialectics or conflicts that we have in the medical community, and I think it's true pretty much everywhere else in systems, is that a person needs to be labeled as sick in order for someone who's helping them to collect reimbursement for the time that they're spending with them. In cases of trauma-informed care, that's exactly the opposite of what we want to be doing. We don't want to say, what's wrong with you? We want to think about what's happened to them and spend more time figuring out how learning what's happened to somebody can then help us with them move forward. And therefore, providing a diagnosis to someone so that you can get reimbursed for that is a little bit conflicting. And I'm not sure how we would get around that, but I think that there are smart people in the city and the country that should be working on this with us so that we can find out how to support the work that we're doing. Our local funders, including Scattergood and Stoneleigh and United Way and others, have really been part of this movement for as long as I can remember. I mean, they were at the table before I got involved, and that was a decade or so ago. These are people who have the influence and the intelligence to recognize and support the work that we have been doing. I think together it's also important to create this think tank where funders all get together and kind of are on the same page around trauma-informed care and the actionable items and the actionable activities that will truly create not just a trauma-informed episode or a trauma-informed activity, but a trauma-informed city. And those funders are out there, and they're working with us, so I'm very happy to be working in Philadelphia where that's supported. Evidence-based work is truly important to do. It prevents us from doing harm, and it also not only finds a good way of doing things, but learns the best way to do things. But as with any other science, there are generations of work that occur. And if you think about cancer care or infectious disease, we didn't not give antibiotics to somebody when we were still working on better antibiotics to give them. And so at any stage of science, we need to use what we think is best at the time in order to just do it. Because if we kept waiting and waiting, it would actually be asymptotic to actually happening. It would not happen. So in our science, we have the physiologic and we now have some truly biological basis for what we're doing, which helps us in the medical community, especially getting out the word and figuring out why we're doing what we're doing. But there's a long way to go. And there's a long way to figure out not just what's good, but what's best. But we can't stop doing what we're doing right now until we figure that out, because it'll happen simultaneously in parallel with what we're doing. My hope for the future, when I think about a trauma-informed city, is that not only are the helpers trauma-informed and working on a very clear path in every activity they do to incorporate the concepts of trauma into their work, but the community members themselves, everybody who is interacting, also has some idea of what is good for them and their family. So that it's like understanding nutrition. Now, we have moved a long way from decades ago till now to understanding what's good for you to eat, and we have a long way to go in terms of probably things changing over time. But more and more people can say, okay, I know that soda is bad. I know that fruits and vegetables are good. These are concepts that seem very simple, but it wasn't necessarily in the 1950s the way that we were thinking. My hope is that families and neighbors and all of the people that interact with them all kind of are on the same page when it comes to understanding what impacts their children, because the children are truly the seeds that are going to form that next generation. And I think those are the important kind of index cases that need to be shaped by both everywhere they touch: teachers, parents, policemen, physicians. To me, the leadership that we have in Philadelphia around trauma-informed care and ACEs is invaluable. And Drs. Bloom, Pachter, Leslie Lieberman, all of the people that we know, John Rich and Ted Corbin, who work with us closely to make this an issue in our institutions. It's not just the science and the evidence that is being built by those leaders, and we are trying as much as possible to get that evidence out into the real world, but it's also the ability to influence our own institutions in ways that we probably couldn't 20 years ago because we weren't in a position to do that. So I feel that I'm working hand in hand with people at that level in their own institutions, and together we're kind of challenging each other and bringing it to the point where we now can say, okay, I've got my administrators on board, finally. They've got theirs as well. And that couldn't have happened a couple of decades ago. So as we age, it's good to see young folks coming in and actually doing the work, but it's also important for us to stay in the work and stay at the table, even though we're not necessarily on the ground every day in that way.